2022, we would like to encourage everyone, if you have any interesting topic, interesting case, even if you have even a topic that's been presented with some of the other specialty and you found it will be helpful for our society, really we would like to appreciate if we just let us know to arrange a meeting to distribute the information for all of our society and increase our knowledge. I think by the beginning of the next month, we will assign by hospital again. But really, I would like to appreciate outside Riyadh. There is many ICUs and also advanced ICU and tertiary hospital, and they are leader in their region. And really, I would like to appreciate to participating to our society to make it very informative and also to distribute the information. Again, I would like to thank Dr. Ra'ad Sadr and Dr. Shayma, and she is Dr. Shayma. She is a senior specialist in the ICU, and Dr. Ra'ad Sadr, he is a pediatric ICU consultant and just joined recently Al Yamama Hospital, and I think it will be a lot of gain for the institution to have Dr. Ra'ad Sadr. Thank you again, and we can start.
Thank you, Dr. Muad. It is our pleasure from the second health cluster, specifically from Al Yamama Hospital, to share with you this interesting case. And Dr. Shayma will start the presentation. So, Dr. Shayma, the mic is yours.
Yes. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, all. It's my pleasure to welcome everybody here to our PICU presentation from Al Yamama Hospital. I'm Dr. Shayma, intensivist from Al Yamama, and actually I am so excited and proud to be with you today and participate in this meeting. We will start our presentation. By prenatal history, our patient is a full-term baby male. Birth weight was 4.3 kg. He was born at 41 weeks gestation by emergency cesarean section due to fetal distress. Actually, the patient born in the Wadmi Hospital with Apgar score at 1, 5, and 10 minutes of 2, 6, and 6 respectively, needed initial steps of resuscitation and intubation. He developed convulsions after that, started postnatally and dosed with phenobarbital, then shifted to Al Yamama Hospital as a life-saving case to be admitted in our NICU. No history of any consanguinity, and he is the third child with no family history of similar condition, and no history of recurrent abortion or any history of unexplained neonatal or infantile death. The baby admitted in our NICU, Al Yamama Hospital, at the age of 9 hours postnatally. He connected to mechanical ventilation and started total body cooling for completed 3 days. Actually, full septic workup done for him and started antibiotics. But at the second day of his life, he developed frequent attacks of hypoglycemia. Glucose intravenous infusion started, and the patient required actually high rate of glucose infusion up to 12 milligram per kg per minute to maintain his normal glycemia. There were also recurrent attacks of refractory seizure, needed the phenobarbital and phenytoin to be controlled. So initial laboratory workup and radio imaging studies done for him in our NICU. Because of the underlying, as I mentioned, refractory and recurrent hypoglycemia started early postnatally. So the patient, we sent the critical sample for him, and the result came with insulin 30.47 microunit per milliliter, and the C-peptide 2.85 nanogram per milliliter with normal level of lactate, growth hormone, and cortisol. So this result was going with hyperinsulinemia. Also, the extended metabolic screening done for him and was normal with a normal level of ammonia and lactate. Initial MRI brain also done for him, showing a severe form of acute profound hypoxic ischemic insult with EEG initially showing frequent electrographic seizure arising from bioccipital and severely attenuated EEG with normal abdominal ultrasound. So summarizing this sample in this slide, which showing the initial laboratory workup and radio imaging studies, that we have a critical sample going with the diagnosis of hyperinsulinemia as an underlying cause of hypo. hypoglycemia with normal metabolic screening, as well as also the initial MRI showed severe form of acute profound hypoxic ischemic insult. Also, the initial echo done for him in NICU showed the moderate left ventricular hypertrophy with hypertrophied septum with no any left ventricular outlet obstruction. There was normal pulmonary venous drainage and normal atria and the normal AV valves with normal right ventricular outlet and confluent pulmonary artery branches. And actually, and this is very important point, that initial echo which is done for him in NICU showed no any evidence of pulmonary hypertension. So this patient initially have no any evidence of pulmonary hypertension while he was in NICU. So after a diagnosis of hyperinsulinism was established, the treatment was diazoxide 8 mg/kg per day, and this is the initial dose we started of diazoxide at the age of 6 days old after we confirmation by critical sample of hyperinsulinemia. And 5 days later, he tolerated the tubal feeding. He tolerated the tubal feeding with normal level. Sorry? My voice is clear for all? Okay. 5 days later, he tolerated the tubal feeding with normal level of glycemia. And the doses actually after that of diazoxide had to be increased from 8 to 10 mg/kg. And after that also increased to 12 mg/kg per day during the next 2 weeks. And finally, the patient discharged after 1 month and 14 days from our NICU for being diagnosed as a case of severe HIE with seizure disorder and hyperinsulinemic hypoglycemia. The patient also prescribed diazoxide as a discharge medication with instruction of twice daily check of sugar before feeding. And also the patient discharged home only for 2 weeks. So he spent about, or he admitted about 1.5 months in our NICU and discharged home after that for only 2 weeks. And during these 2 weeks, he suffered from recurrent attacks of hypoglycemia, required IV glucose infusion twice, despite of persistently taken of diazoxide. So the patient again retransferred to our Yamama hospital, but this time for our BICU as a life-saving case for severely respiratory distress in the 2nd week after discharge from NICU. And at the time of the admission, actually, this was the complaint of the patient and the history of present illness when admitted to our BICU. There was complaining of fever for 1 week, difficulty breathing and respiratory distress for 3 days, vomiting and feeding difficulty for 1 day, and also increasing the frequency of generalized tonic seizure with uprolling eyes for 1 day. Of the admission, and actually as we see all this is a picture and a photo of the patient while admitted in our BICU. He looked irritable with pallor, and he was distressed but not cyanotic in a state of severe respiratory distress. He was febrile with a special craniofacial appearance. As we see, we have here full cheek and full lips with a widely open mouth. Also, we have a prominent epicanthal fold together with a wide nasal bridge and short full nose, as we see, and short neck. Also, there is low scalp hairline with hirsutism and wide distributed hair all over the body, and this was very prominent while we admitting the patient to our BICU. Regarding to his vital sign, initially he was febrile with temperature 38 degrees centigrade, and the heart rate was 150 beats per minute. Blood pressure was 120/55, and the respiratory rate was 60 cycles per minute, and actually his oxygen saturation at room air was 79% at admission. Regarding to our systemic examination, initially at admission to our BICU, regarding to central nervous system, the patient was so irritable with abnormal movements associated with bilateral spasticity and exaggerated deep tendon reflexes with clonus. As I mentioned before, the patient already diagnosed as a severe HIE, and so by the neurological examination, he saw the exaggerated deep tendon reflexes with clonus. Regarding to cardiovascular system examination, there was systolic murmur with no any threat or no gargrism. And abdominal examination, there was no any abdominal distension or gardening or tenderness, but only there is palpable lower border of right tube of liver, only 3 centimeters below the right costal margin. This is, we will see here the video of our patient. This is actual at the time of admission. As we see, the patient was in severe respiratory distress up to grunting with tachypnea and retraction, as we see. Initial oxygen saturation, as I mentioned, was 79% room air, and after that become hardly maintained 90% with 15-liter oxygen by non-breather mask while the patient was in ER. But the patient also actually have marked expiratory wheezing. And so we are treating the patient initially as an obstructive lung disease, given Ventolin nebulization back-to-back for him with magnesium sulfate. And then we tried the non-invasive ventilation because we tried to postpone the mechanical ventilation because of this picture of the obstructive lung region. So we connected him initially to BiPAP with pressure 15/8 and FiO2 100%. After that, we requested for X-ray and echo. This is X-ray, which is done for him at admission, which showing significant initially cardiomegaly with right atrial ventricular enlargement and underlying hyperinflation of the chest. Regarding to the lab work, also we send the routine investigation. We send routine investigation, including CBC, which showed microcytic hypochromic anemia, but initially there is no any hematological figure, and CBC showing no any evidence of thrombocytopenia. With kidney function test apparently normal, with no any evidence of acute kidney injury or electrolyte imbalance, and also the liver function test showed slightly elevated liver enzymes, with all cultures came negative, and also normal coagulation studies. We did echo at admission to our BICU, showing the moderate bilateral ventricular hypertrophy with good systolic function. The ejection fraction initially was 88% with mild pericardial effusion. And actually, this is the picture which we already have had in ICU while admitted in ICU with picture of non-obstructive hypertrophic cardiomyopathy. But we found a new evidences of moderate to severe tricuspid regurg and bidirectional patent foramen ovale. Also, there is a new evidences by echo for marked pulmonary hypertension. As I mentioned before, initially, the initial echo, which is done while admitted in the ICU, there was no any signs or evidences by echo for pulmonary hypertension. But when he referred again to our BICU after 2 weeks from discharge from NICU, he showed the evidences of severe and marked pulmonary hypertension without underlying congenital heart disease. And also that 12 leads electro ECG done showed the sinus rhythm with right axis deviation and 2P wave in lead 2 and positive T wave in lead V1 to V3. Regarding to our hospital post, of course, the patient admitted in our BICU, as I mentioned, at age of 2 months, our primary diagnosis was non-obstructive hypertrophic cardiomyopathy with pulmonary hypertension and respiratory insufficiency to rule out sepsis. And secondary diagnosis, we have hyperinsulinemic hypoglycemia with severe HIE and seizure disorder. Regarding to our hospital course for the patient, unfortunately, the patient was proceeded after that to be intubated and connected to mechanical ventilation after development of oxygenation and ventilation failure with respiratory acidosis. Added to no any proper and satisfactory improvement regarding to respiratory distress ongoing by BAP. We started also the BRVC mode with tidal volume 7 ml per kg and race 35 with beep 6 and FiO2 90. Also, we started nitric oxide with which showing after we put the patient on ventilator, and also we started nitric oxide showing the significant rapid improving. Sorry. Starting off nitric oxides show improving regarding to his oxygenation status. This is actually the X-ray which done for the patient after intubation. As we see here, there is still cardiomegaly, but we have no any evidence of infiltration or consolidation in the thoracic or the lung field. So after evidence of pulmonary hypertension by echo, and after we suspecting that diazoxide may be the underlying cause of drug-induced pulmonary hypertension, so the diazoxide was held at the second day of admission, but actually the patient developed after that recurrent attacks of hypoglycemia required to increase rate of glucose infusion, with order also to give glucagon if the glucose check less than 50 milligram per deciliter. This, of course, after taking the recommendations from our endocrinological team. But from the day 4 of admission, there were also recurrent attacks of convulsions needed to be loaded with levetiracetam, with generally increasing the dose of levetiracetam and phenobarbital until being controlled finally on phenobarb 7 milligram per kg per day and Keppra of 50 milligram per kg per day. Also, during the first week of after admission, and despite of glucose infusion, there were recurrent attacks of hypoglycemia requiring starting of octreotide, which gradually increasing the dose until reached 10 mic per kg per day to maintain normoglycemia. And also 5 days after that diazoxide discontinuation, we repeat our echo and showed that still we have mild tricuspid regurg and hypertrophied right ventricle, but the estimated right ventricular systolic pressure was half of the systemic and mild pulmonary hypertension. So after 5 days from the diazoxide discontinuation, the patient showed slightly improving of the pulmonary hypertension, but still no complete resolution. But after 10 days from the diazoxide, after diazoxide discontinuation, we repeated the echo and showed mild tricuspid regurg with estimated right ventricular systolic pressure 1/3 of systemic and evidences of complete resolution of pulmonary hypertension after approximated 10 days from the stoppage of diazoxide. Also, we repeat the echo after 2 weeks, after completed 2 weeks from the admission to our PICU, showed no any evidences of pulmonary confirmation of no evidence of pulmonary hypertension with good systolic function and underlying pathology of non-obstructive hypertensive cardiomyopathy. So the patient was smoothly extubated at the day 16 after admission to PICU, and actually the patient we controlling the ventilation and oxygenation status, and he showed improving regarding to the oxygenation after starting the nitric oxide, and also after we putting the patient to mechanical ventilation, especially after we holding the diazoxide, and also after we confirmed about the improving resolution pulmonary hypertension. But the underlying comorbidity of the patient, as I mentioned, he have refractory convulsions and refractory hypoglycemia and with disturbed liver consciousness. So this making us to prolong his extubation or the period before the extubation until to be extubated at 16 days after admission PICU. But after that, the patient connected to high flow nasal cannula and gradually went to nasal cannula and smoothly shifted to general physio ward. After that, after completed 30 days in our PICU. Let us to take summary about our case. We have 2 months old male patient was in diazoxide since discharged from our NICU for congenital hyperinsulinemia. We found that he continued to develop worsening tachypnea and progressed to hypoxic respiratory failure, requiring escalating ventilator setting. An echo on hospital day 1 revealed suprasystemic pulmonary artery pressure with severe right ventricular hypertrophy and tricuspid regurg. He also was started on inhaled nitric oxide for pulmonary hypertension, which showed initial improvement regarding to his oxygenation status. Due to our concern for diazoxide-induced pulmonary hypertension, given the temporary relation to drug initiation, his diazoxide was discontinued on hospital day 2, and echo was performed on hospital day 7 after 5 days from discontinuation of diazoxide, showing improving but not resolution of the pulmonary hypertension. But at the hospital day 12, which approximated about 10 days from the stoppage of diazoxide, the echo was performed and showed complete resolution of his pulmonary hypertension. The patient started regimen of octreotide for maintaining normoglycemia, and he was discharged home on hospital day 40. And the patient was followed after that with serial echo, which showed normalization of his pulmonary pressure over a subsequent months. Let us to take about the topics. Our topics for today to be discussed with each other is congenital hyperinsulinemia and the drugs that's used for treatment of persistent hypoglycemia. Also, pulmonary hypertension and what are the updated diagnostic approach and management, and what are the relationship between the diazoxide and pulmonary hypertension in the patient with hyperinsulinemic hypoglycemia. Regarding congenital hyperinsulinism, in brief, it is one of the most common cause of persistent hypoglycemia and refractory hypoglycemia in infancy. We have criteria for diagnosis, especially for elements which is inappropriately elevated insulin level during hypoglycemia, and a requirement of supraphysiologic very high rate of glucose infusion. Number 3, also appropriate glycemic response to glucagon, and finally suppression of free fatty acids and ketone production during hypoglycemia. These are the criteria which used for diagnosis of the congenital hyperinsulinism. These are the drugs which are commonly used for treatment of persistent hypoglycemia or hyperinsulinemic hypoglycemia. Actually, the diazoxide is usually the first line we use for treatment of the hypoglycemia, especially caused by the hyperinsulinism. The dose is usually 5 to 20 milligram per kg per day. And octreotide, we're using 5 to 25 microgram per kg per day, either subcutaneous or intravenous infusion. And also the glucagon we're using, especially in the acute state, and we use it by 1 up to 20 microgram per kg per hour, subcutaneously or intravenous infusion. And nifedipine also we can use 0.25 to 2.5 milligram per kg. Every one of them have side effects, especially the octreotide, GIT usually with nausea, vomiting, and diarrhea, and glucagon if the paradoxical insulin secretion it be done at high dose, apart from the nausea and vomiting, and of course nifedipine causing hypotension. This is in brief about the drugs that commonly used for treatment of hypoglycemia. Let us to concentrate our talking about the pulmonary hypertension and what are the updates in the diagnosis and in the management. Regarding to the pulmonary hypertension, it's defined as resting mean pulmonary artery pressure equal or more than 25 millimeter mercury beyond the first few months of life, actually 3 months. And this document focuses on the childhood disorders of pulmonary hypertension resulting from pulmonary vascular resistance or pulmonary vascular disease, and includes pulmonary hypertension related to cardiac, lung, and systemic disease, as well as the idiopathic pulmonary arterial hypertension. Regarding to the updates in the classification of the pediatric pulmonary hypertension, the majority of the children have transient pulmonary hypertension and were infants with either persistent pulmonary hypertension of newborn or repairable cardiac shunt defects. Of the remaining children, about 27% have other form of pulmonary hypertension like idiopathic pulmonary hypertension associated with congenital heart disease, pulmonary hypertension associated with connective tissue disease, and also pulmonary veno-occlusive disorders. While a significant proportion, about 34%, have pulmonary hypertension associated with developmental lung disease, including the bronchopulmonary dysplasia, congenital diaphragmatic hernia, and congenital pulmonary vascular abnormalities. This is on the clinical base, how to diagnose a case of pulmonary hypertension. Clinically, we suspecting the pulmonary hypertension if we have hypoglycemia despite of the respiratory support, pre-post ductal saturation differences, and maybe also associated with signs of poor cardiac output. By echo, if we have the following criteria, we have a highly suspicion for pulmonary hypertension, or we can diagnose this by echo by elevated pulmonary artery pressure, by right to left shunting at the patent foramen ovale or BDA, by tricuspid regurg and the presence of septal flattening. The estimated pulmonary artery pressure and right ventricular systolic pressure needed to be interpreted in the context of the degree of right ventricular dysfunction, with also the presence of right ventricular with or without left ventricular dysfunction. These are the initial management for any patient and infant with pulmonary hypertension, and all of this we should take in consideration while we are managing the patient with pulmonary hypertension. Of course, we should correct the hypovolemia and support blood pressure because a critical role of cardiac output and systemic blood pressure. Also, we should correct the metabolic acidosis as a metabolic acidosis, as we know, contributing to pulmonary vasoconstriction. Also, we needing to alkalinization with the sodium bicarb to achieve the pH of 7.44, resulted in significant reduce of BVR. But usually, we're restricting this using of sodium bicarb, especially with acute pulmonary hypertension crisis. We should correct any electrolyte imbalances, hypocalcemia or hypoglycemia. We should correct the anemia. If there is underlying anemia, should be corrected because to improving also the oxygen carrying capacity of the blood. We should correct the polycythemia if it is present. And of course, the role of oxygen is very important to reverse the hypoxia. And also, as we know, the oxygen have a potent pulmonary vasodilator and indicated with ventilation perfusion mismatch. And if we have a saturation less than 94%, should be connect the patient to oxygen. But at the other side, we should avoid any prolonged hyperoxia. The intubation and ventilation, it should be done to maintain, of course, in a special patient according to the underlying indication, to maintain the adequate lung volume to reaching the optimum BVR and avoid lung collapse or hyperinflation. Actually, this is a recommendation in the management of pulmonary hypertension in pediatric ICU. Recommendation we have number one, the oxygen should be given when saturation is than 95% in the children with pulmonary hypertension and normal cardiac anatomy. Also, the intravenous prostanoids should be considered to treat the patient with severe pulmonary hypertension. Inhaled nitric oxide may be considered for treatment of pulmonary hypertension in mechanically ventilated patients to improve his oxygenation, and this is what happened in our patients. Concomitant sildenafil should be administered to prevent rebound pulmonary hypertension, especially in the patient who have signs of increased pulmonary artery pressure on withdrawal of inhaled nitric oxide and required again restart of inhaled nitric oxide. And this we usually in our patient was no need for adding of sildenafil because initially, as I mentioned, there is initial and very satisfactory response to the inhaled nitric oxide. Also, the intravenous sildenafil may be considered for treatment of pulmonary hypertension in critically ill patients, especially in those with unsatisfactory response to inhaled nitric oxide. And also, the inhaled iloprost may be effective as the inhaled nitric oxide in patients, especially with post-operative pulmonary hypertension. In children who develop finally signs of low cardiac output or profound pulmonary failure, despite of the optimal medical therapy I mentioned before, so extra corporeal life support may be considered. Let us in brief also to talk about the medication which can be used for management of any patient with pulmonary hypertension, and we classify this according to the underlying causes, and we will start by specific pharmacotherapy to decrease the right ventricular afterload, which is our target, of course. These drugs are epoprostenol intravenous by the doses of we will start by 1 to 3 nanogram per kg per minute, increasing gradually to 60 per kg per minute intravenously. As well as also the iloprost inhaled or intravenously, we use by 0.25 milligram per kg inhalation or 1 to 5 nanogram per kg per minute intravenously. But we should take in consideration when we're using these two drugs, especially the intravenous form of epoprostenol and intravenous form of iloprost, but they causing usually systemic arterial hypotension. So it is better to using inotropes to maintaining our cardiac output and preventing the evidence of hypotension and to overcome the side effects. The third line is inhaled nitric oxide by 2 up to 40 ppm inhalation, especially if the patient in mechanical ventilation. So the first choice for medication for management in the patient or specific pharmacotherapy to decrease the right ventricular afterload, especially if the patient in mechanical ventilation, is the inhaled nitric oxide. Also, the sildenafil intravenously, we can using by 0.4 milligram per kg bolus over 3 hours. After that, we will give 1.6 up to 2.4 milligram per kg per day continuous infusion. But it's said to, we can using higher sildenafil doses up to 7.2 milligram per kg per day if we're using for newborn infant with persistent pulmonary hypertension associated with underlying congenital diaphragmatic hernia. So in this situation, we can using a very high dose of sildenafil intravenously. Also, the oral form of sildenafil, as we mentioned, usually used for the weight more than 8, but less than 8 kg. The oral is not approved, but we can use the oral. It's very important to facilitate the weaning from the inhaled nitric oxide. These are the pharmacotherapy which is using to increase the myocardial function and to counteract the right to left interventricular septal shaft and to overcome the left ventricular compression and overcome low left ventricular output. Of course, we're using the inotropes and vasopressors. Inotropes in the case of severe right ventricular failure in pulmonary hypertension, the inotrope support may be necessary. Especially the milrinone can be used as positive inotrope drug since it has little or no effect at all on the heart rate, but only lowering the PVR. While the dobutamine and epinephrine, of course, improve the right ventricular contractility, but induce tachycardia, which may causing impairment of diastolic filling and coronary perfusion, subsequently lowering of the cardiac output. As the vasopressors also, as norepinephrine and the vasopressin, we can use to increasing the reshifting of the interventricular septum from left to right, which caused secondary to the dilatation, of course, of the right ventricle to improving the tissue perfusion in patients with systemic hypotension. This is our important topic for our today, talking about the diazoxide and its relationship to the pulmonary hypertension in the patient treated with it as underlying hyperinsulinemic hypoglycemia. What about the diazoxide and what is the mechanism of action and what the side effects and what their relationship and how it causing this pulmonary hypertension? Regarding to the diazoxide, the mainstay of medical management of the congenital hyperinsulinism is diazoxide. It is benzodiazepine, historically studied as an antihypertensive, and we know as it's using as antihypertensive drugs, but incidentally, they noted to causing hyperglycemia in patients. Most pediatric patients receive this medication were noted to develop edema and worsen after start simultaneously on diuretics. Also, the diazoxide, its mechanism of action and how it's using for induction of the hyperglycemia. The diazoxide acts to open the potassium ATP channels throughout the body. In the pancreatic beta cells, this serves to inhibit insulin release from the cells, and in smooth muscle cells leads to local relaxation. But tolerance, of course, of diazoxide, because usually we are all using diazoxide as a first line for management of the patient of hyperinsulinemic hypoglycemia. So the tolerance of diazoxide is usually excellent, but sometimes several side effects of this drug have been described. These side effects are hirsutism, seizure, extrapyramidal syndromes, heart failure, hypertrophic cardiomyopathy, immunoallergic neutropenia have been also reported. And the other less common side effects are EDS, coarsening of features, hyperosmolar coma, reopening of ductus arteriosus, and sepsis syndromes with gout. Actually, in July of 2015, FDA issued a drug safety communications warning that pulmonary hypertension had been reported in infants being treated with diazoxide, which resolved with withdrawal of diazoxide. And this is a reference can be found this evidences in it. And so also regarding to our patients, if we remember our patient, the clinical pictures was mainly characterized by pulmonary hypertension, but not the pulmonary hypertension only. We have the hirsutism while we are searching about what are the underlying causes of this situation. Regarding to the diazoxide and pulmonary hypertension, the mechanism of diazoxide-induced pulmonary hypertension is unclear, but was probably due to direct toxic vascular drug reactions, and there is evidences by lung biopsies in these cases, and show that there is already toxic vascular drug reaction. Also, diazoxide open mitochondrial ATP-sensitive potassium channels and cause release of excessive cytochrome C and overproduction of hydrogen peroxide, leading to pulmonary hypertension. So this is series which we found related to the diazoxide induced and what's the mechanism of induction of pulmonary hypertension. And also it is possible that it could have a dose-dependent effect on the pulmonary hypertension, and we will discuss this later in the next slides. And it has also documented that the pulmonary hypertension may be more common in premature infants. Actually, in infants, the incidence of pulmonary hypertension could be higher in general, as currently they don't routinely get echo after initiation of the drug. This is very important slide. We're collecting here all the case reports, what's related to the diazoxide-induced pulmonary hypertension. Let's start by the first case report, which is done at 2004. The age of the patient was 43 days. And also the dose of at which the diazoxide-induced pulmonary hypertension was 17 milligram per kg per day. And actually the patient recovered from the pulmonary hypertension after 5 days from discontinuation and cessation of diazoxide. Regarding to the other case report, this is the next one, which is done at 2011. Actually, his patient was 6 days old, regarding to the age of the patient. And the dose of diazoxide when the patient began to develop pulmonary hypertension was 15 milligram per kg per day. And also, we found here the patient recovered after only 1 day from his pulmonary hypertension after cessation of diazoxide. And as we see here, we have no, in this patient, there is no any underlying condition, there is no any precipitating factors. So the patient already recovered rapidly once we stop of the diazoxide by 1 day and become recovered from pulmonary hypertension. Also, in another case report, which is done at 2017, this patient aged 5 days old only, and the dose of diazoxide was only 12 milligram per kg per day when the patient developed pulmonary hypertension, and he recovered after 40 days from the stoppage of the diazoxide. He recovered after 40 days from pulmonary hypertension. As we see, the patient already here was having a Beckwith-Whitman syndrome and premature and small for gestational age. So we have here many risk factors underlying, maybe causing of his prolongation of recovery from the pulmonary hypertension. Here, another case report. It's done most recently at 2019, and the age of the patient was 16 weeks at the diagnosis, and the dose of diazoxide when pulmonary hypertension discovered was 15 milligram per kg per day. And actually, the patient take more than 2 weeks to be recovered from pulmonary hypertension after we DC or after they DC the diazoxide. And also this patient was extremely premature and low birth weight, so we found here it took more than 2 weeks to be recovered. And finally, this case report, which is done at 2020, and the patient was 20 weeks age, and his dose of diazoxide was only 11.5, and this is the least dose we found in all case reports about the diazoxide dose. It was 11.5 milligram per kg per day only, and the patient actually also recovered after only 1 day from the after the cessation of diazoxide. He recovered after 1 day from the pulmonary hypertension. Let us to see, this will summarize more the previous case reports and compare between our case and the other previous studies. Let us to starting about the duration it took to development of pulmonary hypertension. In our case, it took about 50 days for development of pulmonary hypertension from the beginning of our management. While in the previous studies, it indicated that the time from the diazoxide initiation to the onset of pulmonary hypertension is very, very wide range. It is from 3 days up to 103. And this is what I mentioned about the indicating or the presence of underlying comorbidity or other risk factors which may assist or may causing either fastening or delaying the onset of pulmonary hypertension. Number two, also in our case, the time from the diazoxide cessation to the disease recovery only after 5 days. As I mentioned before, our patient, once we stop the diazoxide, he become improved from pulmonary hypertension within at least 5 days with complete resolution after 10 days. But in previous reports, as I mentioned in the previous table, it's ranging from 1 day. Some patients recovered only after 1 day from the stoppage of diazoxide, up to 6 weeks for the patient to be recovered from pulmonary hypertension after cessation of diazoxide. Number three, related to the dose of diazoxide. We mentioned our patient increasing, as you remember in the beginning of my case report. The diazoxide, we started a dose of 8 and then increasing gradually to 10 and reaching 20 milligram per kg per day within 30 days after drug initiation. In contrast, the other reports, the dose was ranging from 11.5 actually, or 12 to 17 milligram per kg per day. So the previous studies has reported that the diazoxide dose exceeding 12 milligram per kg per day in most cases when pulmonary hypertension developed, and this is going in line with our case. Also, in all reports cases of diazoxide-induced pulmonary hypertension and heart failure, the drug was discontinued 6 to 13 days after the admission. But in our case, when we suspecting the diazoxide to be underlying causes of pulmonary hypertension, especially after we excluding the other causes of the underlying pulmonary hypertension, like the parenchymal lung disease or other respiratory causes, so the diazoxide discontinued only in the 2nd day, and this is causing early, rapid recovery, actually, from the respiratory manifestation and the gradual reduction of pulmonary artery pressure. So our conclusion for today case report or case presentation, our patient developed pulmonary hypertension while taking diazoxide for congenital hyperinsulinemia, and there are resolution of pulmonary hypertension after withdrawal of diazoxide. Pulmonary hypertension was evaluated by echo at regular interval, and also we first introduced nitric oxide to treat pulmonary hypertension. After that, the estimated pulmonary systemic pressure ratio dropped slightly until normalized. Pulmonary hypertension was primary due to a diazoxide adverse side effects since it develops after starting diazoxide and disappeared after the diazoxide withdrawal. Of course, after I mentioned after exclusion of other causes of pulmonary hypertension. Our recommendation and home message for tonight is that diazoxide therapy for infant with congenital hyperinsulinism is associated with the threat of pulmonary hypertension and heart failure. So periodic echocardiography may be helpful for the infant under long term of diazoxide therapy. And it's better to be done prior to that 5 days after the initiation of diazoxide therapy, as well as routine surveillance during the treatment. Also, the parents should be counseled about this serious but rare side effects. so that if their child demonstrating similar symptoms or decompensates, this rare side effects could be communicated to providers who may be less familiar with diazoxide and its potential consequences. And thank you very much.
Thank you very much, Dr. Shaima. And actually, it was really a challenging case for us in Al Yamama Hospital. And as we know that the pathophysiological classification of pulmonary hypertension as pre-capillary and post-capillary, and the challenge from the get-go that we exclude the post-capillary pulmonary hypertension, especially with the background of hypertrophic cardiomyopathy. So really special thanks to our colleague in pediatric cardiology team. Actually, they really make sure about the left-sided obstructive lesion was not there. It was really interesting after we stopped the diazoxide and about short course of nitric oxide to resolve his pulmonary hypertension. So the floor is open for any question and comments from our senior consultants and junior or any colleague members. So any question or comment?
Dr. Baal, do you think,
Yes.
thank you, very informative lecture. Just to mention about the patient presentation initially, it was a fever and respiratory symptoms. Do you think maybe have a pneumonia that contributing factor of pulmonary hypertension? And after being resolving and it's a big improvement after like with the disconnecting or discontinue of diazoxide.
Yes, thank you, Dr. Muad. And really, it was really in our mind, actually. Yes, there was a history of like fever and respiratory symptoms. But if you go back to the X-ray really on the presentation, there was some heaviness, especially in the right side. Actually, it was significant cardiomegaly. And one trick here initially that, as we know, pulmonary hypertension, when it causes dilatation of the main pulmonary artery or the PAs, it can compress the airway. And actually, initially, we got really a clinical picture of obstructive lung disease. I don't think really it is related to pneumonia because Dr. Shaima, you can go to the X-rays. Just within a few hours after intubation and starting nitric oxide, his lung fields were very clear. So I think it will, this is, you see, this is just shortly after the intubation. And we can see clearly here, there is really no pneumonic infiltration. And I think even the previous, if you go back to the first X-ray, if you can appreciate here, we have significant cardiomegaly, and the right side, there is some heaviness. And I do believe it is maybe not pneumonia. And as we heard from the lecture that diazoxide even can cause edema. And really, the patient was having even soft tissue edema and coarse features. So I think maybe most likely it is related to diazoxide treatment. So this is really my opinion. I'm not sure also if we have our senior consultant, if they have any comment.
Hello, Assalamu alaikum.
Alaykum assalam wa rahmatullah.
Thank you for this nice lecture, Dr. Shayma.
Yes.
Regarding this diazoxide, do you have to use it? I mean, we have other agents like octreotide and glucagon.
Yeah, of course. Yeah. As I mentioned this in the case presentation. The patient actually was so refractory hypoglycemia. After we stoppage of diazoxide, we give an intermittent glucagon according to the reading of glucocheck. But we have after that had to enter the octreotide, and actually we upgrading also the octreotide until reaching 10 mic per kg per day until we controlling the hypoglycemia.
And what was the eventual treatment? I mean, he went through.
He's discharged he's discharged already on octreotide.
I mean, eventually would be for surgery or.
Still, we didn't do further investigation regarding to the hyperinsulinemia, but we give recommendations, and he already following by the endocrinologist.
And do you think the smaller doses is better than, I mean, not reaching the 12 milligram, which might cause the hypertension?
This is for
if you have another case. Yeah, no. I mean the diazoxide for next. If you have another case, similar case.
Yes.
So you will recommend.
After this intervention and after this case, we facing it. Of course, we will shifting before we reaching this high dose, because all the reports agree about the dose dependent of diazoxide for induction of pulmonary hypertension. So for me, I will not going for high dose of diazoxide. After that, we can shifting to the second line. It is better to give a large dose of diazoxide.
Thank you very much.
Thank you. Welcome.
Thank you, Dr. Iman. I think, actually, I even invite our senior endocrinologist, Dr. Badi Al-Anizi. I'm not sure if he's with us. And actually, as we review the literature, the congenital hyperinsulinic hypoglycemia, the first line of management is the diazoxide.
Yes.
And actually, when we suspect this complication, we stop it from the get-go. And really, it was great discussion and continuous plan with the endocrinologist. And we shift him to octreotide. It takes some time to control. And I think they have a plan that they will follow up. And as you correctly mentioned, sometimes they can do pancreatectomy or other surgical intervention if it is refractory hyperinsulinemia.
Okay, thank you.
Dr. Raed or Dr. Shayma, can you allow me? Just one question. After you're reviewing all the cases, do you think there is a true pathology that's related to preterm, that they have like very rapid hypertension and very rapid resolve? It's maybe related, maybe reopening of the BDA, different from the others. They have take time to having pulmonary hypertension. And also, what exactly will do diazoxide in the pulmonary as remodeling, or what's exactly physiology or pathophysiology?
Regarding the pulmonary hypertension, how the diazoxide induced the pulmonary hypertension, I will take this point from your question. All the theories we searched what are the underlying pathophysiology and what are the underlying mechanism for induction of pulmonary hypertension by diazoxide. Actually, we find only the induction of direct toxic vascular effect by the induction of the increasing the production of the hydrogen peroxidase and also increasing the cytochrome C. And this is causing damage. Maybe all the effect of diazoxide is direct damage and direct toxic effect on the blood vessels. This is maybe and all of this just a series. There is no definitely and clear mechanism for why the diazoxide induced pulmonary hypertension.
So how you explain that rapid resolving if it's really lead to the damage of the vascular?
Actually, this is not our result only. I take an evidence-based evidence about the older case reports, which is discuss this issue. I think if you go back to the case reports tables, we have many patients, about 2 or 3 case reports that only 1 day after they see the diazoxide, the patient recovered from pulmonary hypertension. Of course, if there is any underlying causes for pulmonary hypertension, it will not take 1 day only to be recovered. I don't know why it's this rapid recovery, but for our patients, it takes about 10 days after we DC the diazoxide for the improving or resolution of pulmonary hypertension. I think because the patient also have no underlying predisposing factors, which may prolongation of the recovery or take the more long duration to be recovered from the effect of diazoxide. The patient and they maybe enter in the category of secondary pulmonary hypertension.
Yes, Dr. Maad, I think you are you are right. Yani sometimes if it is really maybe it doesn't reach the stage of remodeling and fibrosis. Maybe it is early on, and really when we review literature, this is only just hypothesis. It is really the actual pathophysiology is not clear. But most of the pediatric studies showed, as we see from the case reports, complete resolution, even sometimes within 1 day. And actually, there is also randomized, there is actually multi-center study in UK in adult patient, and they review about 77 cases of diazoxide-induced pulmonary hypertension. And the same concept, they found that just with the discontinuation of the medication, most of the patient, they will have resolution of their symptoms and pulmonary hypertension in short time. And they found in this adult study about 7% of diazoxide group or diazoxide receiving patient, they have pulmonary hypertension. And as I told you, really the challenge here to relate the pulmonary hypertension to diazoxide is a challenge. And as I told, as I discussed, the X-ray really doesn't seem that it is pneumonia. Within short, duration, there is completely resolving of the looks like pulmonary edema, and also the significant improvement with only nitric oxide. We don't have a picture of ARDS. This is, I think, most likely maybe it is related to the drug. And as I mentioned, really, the cardiologists, they exclude the pulmonary venous like obstruction or left-sided heart lesion, which sometimes cause post-capillary pulmonary hypertension. And it can sometimes really give the picture of the X-ray that we saw initially. As we know, post-capillary pulmonary hypertension will give you like pleurotheric congested lungs, and usually the pulmonary vasodilator will not be effective in such cases. So the floor is open for any other comments or question. Dr. Maad, if you have any comment?
Thank you very much. Just the last one. Is the possibility of the PDA in small ages and preterm that lead to the pulmonary hypertension?
Actually, our patient is not a preterm, is post-term actually. And yes, there is, if you observe the case reports, that sometimes with diazoxide there is a reopening of the ductus and maybe can cause like pulmonary overflow, and with then later reversal of the shunt and pulmonary hypertension. It can, I think, especially in the preterm, can lead to such complication.
Thank you very much. The last thing is one of our colleagues just mentioned, because it's recorded, could you please mention that there is a consent being taken from the family regarding the picture and video?
Sure. Actually, it was a verbal consent. And thank you for this notice. Yes. Any other comments or questions from colleagues?
Any question?
Okay, I think if there is no more questions or comments, we can conclude our meeting today. I would really thank all the audience and participants and all colleagues who joined us this evening, and I hope that we will meet in the future. Any comment, Dr. Maad? We can conclude our meeting.
I would really thank you, Dr. Shayma and Dr. Ra'ad, for very informative and interesting case. Thank you to participate, and I would appreciate British guys to participating for the next meetings, inshallah. Thank you very much.
Inshallah. Thank you.
Are we done, Doctor?
Yes, Ms. Rose. Thank you very much.
Okay, thank you, Doctor. Night.
Good night. Thank you.
Thank you.